Okay. Thank you. Good evening. Now I can unmute.
Yeah, you're audible now.
Yeah.
Manas, how are you?
Fine. Could you manage to get the visa or
Hi, how are you?
is,
Did you start recording?
so we have 4 minutes to go. Did you check your this thing slides, Anand? Can you share and check it's working or not?
Sure. Should be able to see my slides now.
Yeah. Can you change? Check. Just change the slide. Yeah. Request Dr. Albert, can you please check it?
I'll stop sharing.
And Albert is not there. Dr. Linda is there. Yeah, can you please check whether she you please share your slides.
Sure. Should be okay.
Yeah, you just check. Go to the next slide. Dr. Dattatraya is there. Okay, Dr. Albert has come back. But Albert, can you please share your slide? We'll check it's working or not. Dr. Albert, can you please share your slide?
Где? Окей, на презентацию показать. Нет. Окей?
Yeah, yes.
Окей? Окей.
Yeah, that's fine. Is Dr. Dattatraya there? Yeah, can you please log in? I just want to check, share your slide and check it's working. Yeah, just unmute yourself, just share your slide.
Dear friends, I think
So
we can start. Abujar is with us, Manas is with us.
Okay. So we start.
This is our 7th and 8th symposia, online symposia. We will start with, and I will give the moderatorship to Abujar and Manas.
Okay. Thank you, Dr. Prasanna, for agreeing to organize something on glioma. Because there has been a lot of changes in the strategies of management of glioma, and histopathology has actually changed the way we treat the patients. Before we start, Dr. Anandh speaks on how biopsy histology has changed the way we look at tumors. I request Dr. Abujar to get a few comments on the topic.
Hi everyone. Today it's an honor to moderate this session with the Professor Manas. Today we will talk about two advances in the management of gliomas with the expert. Firstly, Professor Anandh will start. I think you can share your presentation and we can start the session.
Yeah, Dr. Anandh,
Thank you. Yeah, thank you. I am sharing. If you can see my slides.
Yes.
Yeah. Thank you so much. I grateful to the WFNS Education Committee, Dr. Zalili and Dr. Manas, for providing me with this opportunity. The talk is under the heading of Advances in Management of Gliomas, and my topic is Has Pathologic Classification Changed? So the first disclaimer, I'm not a pathologist, I'm a neurosurgeon. but with a bit interest in neuro-oncology and most of my knowledge in this field, I thank my teacher, mentor, and colleague, Dr. Vani Santosh, from whom I have learned a lot, and I have borrowed a lot of slide material and information to share with you all. So at the outset, again, has pathologic classification changed? The answer is simply yes. Why does it keep changing? Because we do need accurate classification. That is the need of the hour because of clinical management of individual patients. They keep differing. We all have seen a lot of GBMs do very well in spite of the worst prognosis, and some of the good, great so-called tumors do badly in spite of us expecting them to do well. So we need more accurate classification. We need uniformity in clinical trials for experimental studies, population-based data, and support from external agencies, so on and so forth. So the classification initially was the old one. Then there has been multiple editions that have happened since 1926. Till 2007, there was grossly not much of a change. Then there has been an explosion of molecular data with IDH discovery. And then the 2016 classification was considered a major breakthrough. But from 2016 to 2021, there has been a real explosion, further explosion due to multiple C-Impact Now publications, that is the consortium to inform molecular and practical approaches to CNS taxonomy, not official WHO. There were 7 publications which has revolutionized the way we look at and classify these tumors. And now it has led to the hybrid taxonomy. So what are the changes that we are looking in these tumors classification? So if you see, is it just a facelift change, or are there deep changes within the tumor grading? Yes, there is a revision of the taxonomy. There is a revision in the way we grade these tumors. It is not just based on histomorphology. There is restructuring of tumor groups, and there are new tumor types and subtypes. Then the terms not otherwise specified and not elsewhere classified have come in with more meaning, and a layered integrated reporting is being encouraged. The Arabic numerals that we know of 1, 2, and 3 has got replaced to reduce transcription errors, and the CNS WHO grade is introduced to identify it with CNS. So you would see like this, you have a tumor, and then it says CNS WHO grade in the numerals 2, 3, or 4. Now, about NOS and NEC, this may be quite confusing for the neurosurgeons. When we have not done certain tests to further characterize the tumor as advised by the WHO, then we have to put our diagnosis as per histomorphology and add the letters not otherwise specified next to it, because we have not specified it further with further tests that are needed. But once you have worked out all the tests and you don't find it fitting in to any of the current WHO diagnosis, then it becomes not elsewhere classified. I'll elaborate on this further as we go in this talk further. Final one is the layered classification. So the site comes first, and then the identifier. So like this cerebrum, and then the identifier, what is the diagnosis? The integrated histomorphology and molecular diagnosis comes first. So it's say a supratentorial ependymoma. It says NOS, that means further classification has not been done by further markers suggested by the WHO. Then the histopathological classification is enumerated. Then the CNS grade is enumerated. And then the molecular information, what has been done or not done, is summarized. So this way, it's a more elaborate descriptive diagnosis rather than just giving a singular diagnosis, which is more informative. The last is that they have also specified essential criteria and desirable criteria. So essential criteria are definite must-have features, and desirable criteria can be supportive but not mandatory. So we need not exhaust the patient's bank to get a diagnosis. If we have the essential criteria satisfied, it's enough. So we come down straight to the classification. So this is the broad classification of WHO 2021. The glial glioneural tumors are here. So as you can see here, these are the types. Rest we are not going to concentrate today. And even in these types, I'm just comparing it to the WHO 2016. You see, this was the glial glioneuronal tumors and the astrocytic tumors. But now they are classified into major 4 types. That is the adult type diffuse gliomas, the pediatric type diffuse high-grade gliomas, pediatric type diffuse low-grade gliomas, and circumscribed astrocytic gliomas. So we are again not going to deal with the pediatric and circumscribed gliomas today. We are straight going into the adult type diffuse gliomas. So if you actually see the first time, the gliomas as classified as adult type or pediatric type. This is the major difference in the new classification. Now further, if you compare between 2007 to 16, 2007 looked very simple. It was just diffuse astrocytoma, anaplastic astrocytoma, glioblastoma. Anaplastic and malignant were being used frequently, and oligoastrocytoma was existent, gliomatosis cerebri was existent. In 2016, the IDH mutant type or IDH wild type came as a suffix to the main ones that were described in 2007. And the term of oligoastrocytoma was still present, and gliomatosis cerebri had been deleted even in 2016. Now, if you look at in 2021, it has been grossly simplified. The adult type diffuse gliomas only 3 types. They are either a IDH mutant astrocytoma or a oligodendroglioma, which is IDH mutant 1p19q co-deleted. And the IDH wild type is a glioblastoma. So these are the only 3 entities that the adult type diffuse glioma is existent as of 2021. That says a lot about the understanding. Now, how do we go down to break this down? Again, I'm showing you the old classification, which had astrocytoma, oligoastrocytoma, oligodendroglioma, and glioblastoma. It was further divided into IDH mutant or wild type, and then further classified as whether it is diffuse astrocytoma, oligo, or glioblastoma type. But what is it now? It is the oligoastrocytoma has gone completely. We are overarchingly seeing the IDH type. So it is either IDH mutant or IDH wild type. If it is IDH mutant, we do a ATRX loss and T53 mutation. This is characteristic of a diffuse astrocytoma IDH mutant. The other side is the absence of these two. There is ATRX is retained or T53 is not mutated, and they are characterized by 1p19q co-deletion. This is diagnostic of oligodendroglioma. And this stream has only grade 2 and 3. The astrocytoma has grade 2, 3, and 4. The Roman numerals are replaced by normal 2, 3, and 4 numbers. There is no more a secondary glioblastoma. That means you don't call a IDH mutant glioblastoma. They are IDH mutant grade 4 gliomas. All glioblastomas are IDH wild type. There is no more IDH wild type grade 2 or grade 3. We'll see them shortly. Now we'll go into each of these 3 types. So this is the astrocytoma IDH mutant. So what is the essential criteria? It should look like a diffuse infiltrating glioma on histomorphology. IDH mutation should be positive. There is a loss of nuclear ATRX expression or ATRX mutation and or exclusion of 1p19q co-deletion. The desirable factor is the T53 and methylation profiling or astrocytic differentiation by morphology. So this shows, the slide shows the IDH mutation, the ATRX loss, and the P53 mutation, and this is retained. That is CDK and 2A. This is for grading, and this does not apply for the diagnostic criteria. If by these you diagnose it as an IDH mutant astrocytoma, and you have a grade 4 morphology like necrosis or mitotic activity with microvascular proliferation, straight away it is grade 4 astrocytoma. However, if there is only grade 2 or 3 by histomorphology, then a CDK and 2A needs to be done by a FISH approach to know whether they are aggressive behavior or not. that will straight away take it to grade 4. So in summary, for astrocytoma IDH mutant, you have 3 grades. This IDH mutant glioblastoma is not there anymore. It's called IDH mutant grade 4 glioma, which could be histologically defined, or it could be defined with FISH of CDKN2A. Now, this is the way the grade goes. If it is well differentiated, no anaplasia, no mitosis, no microvascular proliferation, it is grade 2. Same with it, grade 3, if it is only mitosis is present, then you need to do a CDKN2AB homozygous deletion to confirm they are still grade 2 and grade 3 and not going to have aggressive behavior. So this is the secret for those tumors which look benign, grade 2 or grade 3, but who tend to perform badly when you follow them up. They may be CDKN2A positive. It's about in 20% of cases. But if directly in histologically they are having frank features of grade 4, it's only or. You need not do CDKN2A in all the patients. It's either or. So once you find these histologically, they are straight away CNS WHO grade 4 astrocytoma IDH mutant. So that is summary of this. 3 grades, 2, 3, and 4. If mitotic activity it is 3, microvascular proliferation necrosis it's 4. No change till here. If it looks like 2 or 3, you are in doubt. You have to do a CDKN2A for co-deletion to grade it to grade 4. If you are not able to do this, then you have to add the NOS next to it. So it is ATRX loss, P53 mutant, which are diagnostic essential criteria. Don't forget the T2 flare mismatch. I won't cover it here for lack of time. Prognostic factors remain age and extent of resection. That is not changed. Just giving you an example of a lady here with a insular glioma with a residue left because it could not be resected because of speech disturbance. She had ATRX loss, 1P19Q not co-deleted, grade 2 histology. So we didn't know whether to observe this or treat it directly with RT. To do that, we did a roll of CDKN2A. If this was retained, so we could continue observing this patient than giving upfront treatment because we know they are unlikely to progress like a grade 4. Another example of this patient who had a diffuse astrocytoma with endothelial vascular proliferation, mitosis frequent. So this is directly grade 4 because of histomorphology. But see here, the pathologist has reported IDH positive. So this becomes IDH mutant grade 4. However, they have asked for a CDKN2A mutation. This is superfluous and not essential. So I think I was able to bring out that difference. Now in oligodendroglioma, this is IDH mutant, 1P19Q co-deleted. So you have a glioma. Here the ATRX is retained, P53 is not mutated, and FISH shows 1P19Q co-deleted. This has become a diagnostic marker. So this diagnostic marker is essential 1P19Q co-deletion, and it is inversely related to nuclear expression of ATRX, which you can confirm with also a third promoter mutation. So in cost constrained circumstance, or where FISH is not available, one could go ahead with ATRX under third mutation to confirm whether it is an oligodendroglioma. However, in WHO, this is essential criteria to diagnose oligodendroglioma. So for oligos, there are only 2 grades. There is no grade differentiation with any marker. Diagnostic marker 1P19Q. ATRX could be used as a useful mutually exclusion tool. And the prognostic factors remain age and extent of resection, even in these tumors. Now coming to the third group, that is the wild type. So the IDH wild type, practically all of them are glioblastomas. There is no IDH wild type grade 2 or 3 in this nomenclature. But if microvascular proliferation necrosis is not there like the old classification, we have 3 additional markers: the EGFR amplification, third promoter mutation, and +7, -10 chromosome copy number changes. If these are present, in spite of the tumor lacking histology of grade 4, the tumor is glioblastoma, that is IDH wild type CNS grade 4 tumor. If all these are negative, then it's a different tumor. It may not be an adult type diffuse glioma. It could be a pediatric type glioma. One has to go for IDH sequencing, confirm it is still IDH negative, and then go for histone mutation. I'll cover that shortly in the next few slides. So IDH wild type is grade 4, grade 2 or 3 doesn't exist. Histological criteria is enough. You need not do these if microvascular proliferation necrosis are obvious. If it looks like a grade 2 or 3 IDH wild type tumor in spite of sequencing, one has to do one of these three. Either of them is positive, it confirms a GBM. If you're not able to do them, you can report it as IDH wild type NOS, GBM NOS. Give you a quick example clinical scenario here, a biopsy done for a deep-seated lesion. You can see that here there is no necrosis or microvascular proliferation. Patient was IDH negative. So pathologist asked for sequencing and 1p19q co-deletion. This is questionable. Sequencing is the right way to go. And sequencing findings showed that it is wild type status. And they asked for MGMT methylation, which is correct. But the final diagnosis, they have suggested both TERT and CDKN2A. This is applicable only for IDH mutant gliomas. Here it has no role. TERT is correct. You could have asked for TERT, EGFR, and +7 -10 if they are available. And if they were positive, then it confirms that it is grade 4 because histologically it is looking like grade 2 or 3. Now we are coming to two other groups. This is the midline glioma. We would have called this DIPG. DIPG term does not exist anymore. It's old term. These are diffuse midline gliomas, H3K27 mutant, histone mutant. This study has to be done, can be done IHC. This alteration is very poor prognosis and IDH has no implication in these tumors. If the tumor is diffuse like this, as you can see, one side involving crossing the midline, involving septum. It is old terminology of gliomatosis cerebri. Nowadays, it's called as diffuse hemispheric glioma. This is the pediatric type high-grade glioma, which H3G34 mutant positive. They have a poor prognosis. If it is negative, again, it goes as not elsewhere classified. If it is not doable, then you have to report it as NOS. Again, IDH has no role. So in short, we can say that the grading has changed. It's Arabic, not Roman numerals anymore. It is in the grades are within subgroups. The terms NOS not otherwise specified if tests are not done or not elsewhere classified. Tests are done but do not fit into any particular category. And the prognostic has become more uniform as the members are more uniform in a group. So this table quickly summarizes the changes. I would not go through them again, it's just a repetition. Just to confirm to the audience, what are the tests that are finally needed to get a proper diagnosis in the new classification? You just need IDH and ATRX-P53 with a MIB count if possible, though MIB is not a criteria. So IDH is easily done by IHC. You can ask for a sequence if it is negative. And ATRX-P53 can be done by IHC. And if FISH is available, 1p19q will give diagnosis for oligo, and this will give for a grading CTKN2A or B. The rest can be easily done with IHC. So most of the classification can be done with IHC. So you can see here, this is a mutant glioma. So mutant glioma, if it is morphology is already microvascular proliferation necrosis, straight away grade 4. This is for FISH. If it is positive, it is oligodendroglioma. If it is looking like grade 2 or 3, you do CTKN2A and it becomes negative. It goes for grade 2 or 3, IDH mutant glioma. If it is positive, it becomes grade 4, even if it looks like grade 2 or 3. Now, this is the group where sequencing is being done. If the IDH is negative, it is IDH wild type astrocytoma. If the sequencing is positive, it goes down the oligo way. Here, if the sequencing is positive, it goes down the astrocytoma way. So we forget these two. These were in the older slide. If it is negative, what do you do? If IDH sequencing is negative, then you do the EGF, and it looks like grade 2 or 3. These three for grading has to be done, EGFR TERT plus 7 minus 10. If they are positive, it becomes glioblastoma wild type. If they are negative, they don't become grade 2 or 3 IDH wild type astrocytoma. It is not elsewhere classified. You're supposed to do the histone mutations here, as I said, to look whether it has a pediatric type diffuse high-grade glioma. And if it is present, then it becomes a pediatric type diffuse hemispheric glioma. One small caveat here, in an elderly patient, you rarely get IDH positive tumors. So if the age is high and the patient is immunohistochemistry wise negative for IDH, one need not insist on sequencing. You can directly take it as glioblastoma IDH wild type. In a younger patient, you would look for a sequencing. And in midline tumors and hemispheric tumors, irrespective of age or grade, please get the histone mutation done. The MGMT need not be done in all patients. It's useful only in elderly patients and in recurrent settings for prognostic or predictive marker. So finally, summarizing, diagnosis grading is still uses a lot of histomorphology. The mitosis, microvascular proliferation, necrosis is still important. Molecular genetics, IDHS diagnostic, ATRXP53 diagnostic for astro, 1P19Q diagnostic for oligo. Grading, if it doesn't look like a grade 4 directly, if it is grade 2 or 3, it may get bumped up to grade 4 if CDKN2A is positive in astrocytoma. If TERT EGFR plus 7 minus 10 is positive, it may get to glioblastoma. And MGMT is only in elderly GBMs. With this, I'll conclude my presentation, and I'm open to any questions now or at the end as the moderators speak. Thank you so much for your attention.
Thank you, Dr. Anandh.